My name is Alex Mitchell. I'm a member of the Lighthouse Lab Services marketing team, and I'll be serving as your host today for our webinar on the future of molecular testing reimbursement. We'll be discussing MolDx, prior authorizations, payer reforms, and more. So we have a great audience today, and we're really excited to be co-hosting with our strategic partners at Quadax. Let me get started by just introducing our speakers really quick before we dive into the material, because we've got a lot to cover today. First off, we have Ann Lambrix, the Executive Director of RCM Consulting for Lighthouse Lab Services. She heads up the division's day-to-day operations. And with more than 23 years in the medical insurance and billing industry, her experience provides an insightful analysis of revenue cycle and payer trends impacting reimbursement. Additionally, Ann holds an MSJ in health and hospital law. Ann's been a longtime speaker for us on these webinars, and we're happy to have her back pitching in for us. Always does a great job. And then alongside her today, we have Tara Cepull. She earned her master's degree with a high distinction in clinical physiology in 2009. I should say her title as well. She's an industry status and outreach advisor with Quadax. After 7 years providing inpatient and outpatient psychological services, she pivoted her career into healthcare and life sciences. Over the past 8 years, Tara has built an extensive executive leadership experience in recruiting and staffing, with a specialized focus on the lab industry. She's worked closely with CLIA laboratory directors, pathologists, and laboratory personnel at all levels, giving her deep insight into the unique workforce needs and the operational challenges facing labs today. And again, we're very excited to have both our speakers on today, and definitely thank them for their time diving into this issue. I'm going to touch on a few housekeeping items before we get started here. You can reduce your chance of a slowdown if you close any apps you might have ready to the background. So if you're lagging, having trouble hearing us, or having trouble with the video, go ahead and maybe try to exit and re-enter the room and see if that addresses the problem as well. This webinar will be recorded, and it'll be automatically set out to everyone after the fact, so no need to ask us for that. And then the slides will be added to the handout section momentarily, and you'll be able to download a PDF copy of those there. If you'd like to ask questions, we're going to run a Q&A at the end, so please feel free to drop those questions into the Q&A section of the chat box, and we'll respond to them at the end as we have time. And if we don't get to address your question today, you'll have multiple opportunities to follow up with both Lighthouse and Quadax. So please make sure you get those over to us. And we're going to run a few polls during the webinar. Those are strictly optional, just for engagement, to help us have a better understanding of the audience members that we're speaking to. So please feel free to respond to those if you'd like, or X them out when they appear and move on. Just want to quickly make the pitch about Lighthouse Lab Services for anybody who's new or hasn't joined us in the past for these webinars. We provide these educational webinars as a free service, a way to educate the broader lab community. But primarily, we provide end-to-end comprehensive services for clinical and medical laboratories. We help start, run, and grow labs, provide staffing, instrument, and RCM consulting solutions. So truly, if there's anything you're looking for in the laboratory realm, we have a solution for you and would be happy to speak with you. But one thing we don't provide is medical billing services directly. Our RCM consulting is more focused on improving processes and auditing, and that's where our strategic partners with Quadax come in. Here's a few stats to speak to Quadax's overall success. But Quadax helps healthcare organizations optimize their revenue cycle, from pre-billing to reimbursement and appeals. With over 50 years of experience, including 30 plus years in the laboratory billing space, their deep expertise and flexible solutions help labs improve efficiency and accelerate payments. Whether billing is in-house or outsourced, Quadax helps support your lab. And you can visit their website or download their one-pager that's available in the handout section if you need any additional information. And now with that, I'm going to go ahead and turn things over to Ann to kick us off.
Thanks, Alex. Just wanted to say how excited I am to be back on this platform with Lighthouse and talking about this topic, the future of molecular testing reimbursement. It's a subject very near and dear, and we work with a lot of clients that just, we're kind of working through how do we navigate this space going forward. So hopefully you gleaned some good information from this presentation today. And as always, I'm available if you need more support. And again, Tara and Quadax as well. To start us off, let's just talk a little bit about MolDx, the program. MolDx has been around since 2011. So over 20 years, this program has existed. It is not a new program. I know many of you may have just started experiencing the requirements for MolDx as more and more payers roll up under it. But really, MolDx started in 2011 with Palmetto, the MAC in the southern region. And we can see over a period of probably about 10 years where more MACs, CGS, WPS, Noridian, all did roll within the MolDx program. So currently there are four MACs that participate with MolDx through Medicare. And there are still 3 lone wolves out there. We've got NGS, Novitas, and First Coast that have their own LCD and policy regarding molecular and genetic testing reimbursement. What we're also seeing is more managed plans. So managed meaning not straight Medicare, not a MAC. This is United Healthcare, for example, Humana, where they're rolling their molecular diagnostic reimbursement programs and policy under MolDx, or really the diagnostic exchange. They're requiring labs to register certain tests under the diagnostic exchange, obtain a Z code, potentially a technical, get their technical, oh my goodness, their TA approved, and will administer through that. So United Healthcare in 2021 did start rolling out for their Medicare Advantage plans. They just finalized rolling out all of their products. So Medicaid, their community care, rolled out the program the beginning of this year, 2025. Humana Medicare is also requiring test registry for certain tests through the diagnostic exchange. And I would argue that there will be more non-Medicare payers rolling under this program. Just to give you a quick understanding of why this program has been successful, molecular and genetic testing continue to evolve. And so I always say the science, the technology is about 10 years ahead of the payer, meaning labs are developing tests and they start to build the test. There's not enough CPT codes to assign a specific test. And so oftentimes labs will use an unlisted or an unassigned code to bill, to submit for a test, a charge for a test. Using unlisted, when you're submitting a claim, we're submitting claims electronically. No documentation typically is attached on the initial claim. Payers have a difficult time understanding what test the lab is billing for because they're using an unlisted test or tier 1, tier 2 codes if you're running a panel. So what MolDx does is the lab is registering that test through the diagnostic exchange, getting a unique identifier, a Z code assigned to that test, and it is included on the claim submission. So when they get that 5-digit Z code, it's actually a Z identifier. It identifies the test to the payer, to Medicare, to UHC, to Humana, and they're able to process and pay accordingly. Medicare is what's known as a pay and chase payer. So with other MACs, if they're not rolling up under MolDx, oftentimes, either what will happen is if you bill unlisted codes or these tier 1, tier 2 codes, because they're unable to identify that test, they'll either request documentation, or you may have experienced they'll pay the claims. They'll pay the claims maybe for a year or two. You think you're covered, you think you're good. And then they come in and do an audit, and then they recoup all of that and say, nope, we're not covering this. So with MolDx, this puts all of the onus on the front end to get that coverage established, to review the clinical utility, to ensure that there is established metrics for the test, and to get almost that prior auth. So I kind of look at MolDx as more of the prior auth for Medicare. And more commercial payers or managed plans, they have attempted to do various programs to identify upfront, doing prior authorization to administer the benefits and coverage for these tests. But because of the success of this program, it may be where it's more cost effective for the plan to scrap that process and roll it under MolDx. So I do expect more plans. As we think of the future, more plans will roll into this program. Right now, as I mentioned, we have 4 Medicare MACs that participate. There are 3 that remain. My crystal ball is saying that perhaps NGS will be the next to fold into the program, simply because I've seen or heard that they have recently hired or placed a new medical director, Dr. Patrick Mann, who was formerly at Novitas and has now moved to NGS. And he is has stronger views on what NGS will cover and pay for. Also, NGS this past year, the gap fill process for assigning rates to either new codes or unlisted or PLAs, the NGS adopted or was given all the prices and all the rationales exactly the same as what was used by the MolDx consortium. That is, again, my crystal ball as far as when. It could be next year. It could be many years down the road. But I do expect that this program will continue to expand. What I would advise labs to do is if you should be looking, if you're running molecular and genetic tests, labs should be running their denials and looking at payers that may be denying for missing information or required fields not submitted. Again, United Healthcare, all of their product lines, Medicare, commercial, and Medicaid, all will require a Z code on certain tests. So you should be aware, if you run your payer mix and you have any of those product types, you should be aware that this will affect you, whether you're in a Medicare MAC that participates in MolDx or not. It applies nationally. Same with Humana. There is some good guidance on Palmetto's. It's actually the Diagnostic Exchange FAQ. If you look under the topics under commercial plans, Medicaid, Medicare Advantage providers, it will provide the links to the roll out the phases that these payers have rolled out this program and what CPTs or tests that they require the Z code. I always just want to make sure that it's very clear that, because we kind of go back and forth with the Diagnostic Exchange or DEX and MolDx. MolDx is actually the Medicare initiative, and it's administered by Medicare. And it requires the registration into the Diagnostic Exchange for certain lab tests. And again, you can get the full list of what lab tests are required to get a Z code. If you don't know, more than happy to help guide you. But the diagnostic exchange is the registry. That is where you will register your test, and then they will assign you a Z code, and then most likely ask for a technical assessment. And that will all be handled through diagnostic exchange. Next slide. There we go. So I just put in some information because I think that we get confused when the payer is requiring a Z code. That is the diagnostic exchange, and you will submit. You will need to register your lab under the diagnostic exchange and then each individual test. All right, on to Tara.
Thanks, Ann. Hey, everybody. I'm so excited to be here. Just wanted to say that really quickly as we dive into dealing with claim denials. Obviously, we all know that it's difficult to navigate various payer policies. You know, they're constantly changing. For example, just to start with an example, United Healthcare recently announced a new policy taking effect on December 1st for 43 states. The 7 other states, the changes will come later. That's Arkansas, Colorado, Kentucky, North Carolina, Nebraska, Ohio, and Rhode Island, for those of you in those states. But this impacted routine testing claims. They will now undergo automated post-service prepayment policy enforcement. And new guidelines are setting the circumstances and the frequency for certain tests being eligible for reimbursement under their policy. Some of these tests include A1C, flow cytometry, inflammatory bowel disease panels, and others. And I just wanted to give that as an example because billing for genetics, genomics, and other molecular testing can actually be even trickier, as Ann mentioned, with the MolDx requirements. So let's start with talking about some of the reasons that claims are denied. Let's start with the codes. And we're all probably familiar with these codes. Ann gave a great explanation about Z codes and where those come from. And, United Healthcare began requiring them in phases last year. As Ann mentioned, they now require it nationwide regardless of your MAC. So you want to make sure that you're using the right Z code to start with when that is required. Obviously, we know what CPT codes are, but different payers oftentimes have different CPT codes for various lab tests. With MolDx testing, those are tied to particular ones, though. In some cases, this means that the billing structure for your lab needs to change in order to align with the MolDx CPT codes to get paid for those molecular tests. And additionally, we're talking a lot about MACs, and I think Ann is going to give some more detail later in the discussion about MACs specifically, but what MAC you're in matters. We know that, MACs are private organizations that process those Medicare claims for those specific regions. They're checking that the correct CPT codes are issued, that proper documentation is given. Like Ann said, they may request additional documentation if you don't provide that. And additionally, they're checking that the claims adhere to the MAC-specific coding and billing guidelines. So those are all hoops you have to jump through in order to get paid, making sure that you're giving them all of this information correctly and completely. Additionally, some of Quadax's clients, and probably some of you, use PLA codes. These are proprietary lab analyses codes. They're developed by the American Medical Association. Essentially, for those of you who aren't familiar or don't use those yet, they're a subset of CPT codes that are used to identify specific lab tests, particularly multi-analyte assays and genomic tests in particular. So that's why I wanted to mention that on this webinar. Some of Quadax clients were reporting that it was confusing as to what to bill. Historically, a lot of them use PLA codes with the CPT code that is appropriate. But some payers haven't yet linked Z codes with PLA codes, which is making it super confusing as to what exactly to bill. So what we did was, communicated with the client and with those payers on strategy. How do we build this in order to be reimbursed? How do we comply in order to not be denied? This involves strategic ongoing planning and communication between the lab and the payers. To make things more confusing, as if we need more hoops to jump through, denial codes are not consistent across payers. So when you receive a denial for a claim, you have to really pay attention to that code and know what it means for that particular payer so that you know how to correct it and appeal. And then finally, newer payers like Optum are rapidly scaling when it comes to MolDx and molecular testing codes. You must catch the anticodes, add the correct code to the appeal, and then also address previous denials in the same manner. It's a lot of administrative work for labs, and I know a lot of you are already stretched thin or understaffed. So it's just something that you have to keep in mind. Let's talk about how do we avoid those denials now. Now that we've, there we go. Let's talk about how do we avoid those denials now that we've discussed, some of the things that contribute to getting denied. First and foremost, I can't emphasize this enough, regular audits. Most experts in the industry say at least annually you need to be auditing your billing and reimbursement practices, whether that's internally done or it's outsourced to an expert. It needs to happen. So make sure you're devoting that strategy. It will pay off. Medical necessity is of the utmost importance. You have to ensure that the tests you're conducting and that you're billing for are medically necessary, that clinical utility that Ann mentioned. This is ongoing and something that you have to monitor every day, regularly. The codes that we talked about, using the correct ones in the correct combination for each specific payer. So that's three things: correct codes, correct combination, the right payer. That's important. Z codes, CPT codes, PLA codes, the appropriate ones for the testing you're providing, it all has to be understood and correctly submitted in order to get paid. Eligibility is a big one. We have to ensure that the tests are covered by each individual payer. Errors in eligibility are probably costing your lab, and in a lot of cases, they're a big cost to revenue. Verification of eligibility, and that includes prior authorization, which I'm going to go into more depth in shortly. It has evolved. It's no longer a routine administrative task like it used to be. It's actually a strategic priority, and that's due to the increase in the complexity of these payer requirements that are, like I said, rapidly changing. I think there's a poll about the claim denials that you might be experiencing. So I would encourage everyone to go and answer that. I'm going to give a few statistics here. 10 to 20% of revenue is tied up in denials. 60% of these denied claims are actually never recovered. And did you know that it costs about 4 times more than the original claim to resubmit or rework a denial? It's really costly to labs. Most common issues that we see with eligibility verification include expired coverage, incorrect patient data, or missing authorization, or maybe missing patient data like Ann mentioned. These are all compounded by the frequent changes in the eligibility requirements by payers. So you have to stay on top of those requirements and make sure that you have all of the information, it's correct, in order to verify eligibility. All of that leads to submitting a clean claim. It's paramount. These are less likely to be denied because they have all of the information, nothing is missing, and there are no errors. Additionally, I wanted to touch on quickly the current government shutdown. Labs have to stay abreast of CMS notices that have to do with things like the current government shutdown. For example, on October 15th, all MACs were directed to temporarily hold certain claims with service dates on or after October 1st. Now, these were just for services under the Medicare physician fee schedule and only tied to expired legislative payment provisions, but they need to be flagged and monitored on an ongoing basis until they're paid or denied. These are not applicable for services billed under the clinical laboratory fee schedule. Just want to clarify that, and I'm not trying to confuse anyone. So if you're experiencing any payment delays there for tests you're billing under the clinical laboratory fee schedule, those are due to something else and need to be investigated.
Hey, Tara, can I just chime in on a couple of things? I've been writing some notes. Just a couple of things just to clarify with folks that are billing under the MolDx Diagnostic Exchange Program. I just want to make sure that you understand that when you submit your test through the DEX, you will get a Z code. That is an identifier of your test, your specific test, and your lab. Then you go through a technical assessment and hopefully those get approved. The DEX will assign you a CPT code. That CPT code that they recommend, you have to submit on your claim, as well as that corresponding Z code in the appropriate field. So you both have a CPT and a Z code when you submit to the payer. The TA, if it's pending or denied, the payer may not process and pay. So just to make sure that's very clear, you have a Z code, you have a CPT code, as well as an approved TA that all have to come together in order for you to receive payment. The other thing is 100% agree with Tara's, talking about audits. We do auditing and, that has always been our stance is regular audits equal better visibility and preparation for payers to come in and audit you. And so then you're not holding the bag, so to speak. If you're getting a clean audit every time, that's actually good. That means you're managing your lab appropriately. But it also means that you're also prepared for when policies change and coding guidance changes. Doing these regular audits with a team of people that have industry knowledge will support your lab as you continue and grow your business. And then as far as the government shutdown and the payment hold, I do believe that there was a further guidance noted all holds have been lifted. So there should be no one receiving any communication from Medicare that they're holding payment as of now. So
thanks, Ann. Yeah, I was just going to say, any that you flagged, then you should see that payment come through. And if they're
Correct.
Still not happening, there's something else going on, and more work needs to be done to investigate that.
Absolutely.
I appreciate your clarification on the codes being given to you through the DEX system. That is absolutely true. It's not rocket science that you have to figure out yourself. It is just something that you want to make sure that you register and you get assigned to you, and then that you include on all of those claims, because if you don't, it obviously leads to those denials. So really,
I just think of the Z code as that identifies the test and so it all has to link up. I see a question. You don't need to bill with what you think you should bill. You bill what they tell you to bill, because that is how they link up that Z code to your unique test and approved the technical assessment.
Yeah.
So if you bill with a different CPT code, even if you include that Z code, it's going to get denied. And that is a big problem. I think, we get a lot of questions about that. I think, so just make sure that you look at that. MolDx will provide, or DEX will provide the list of your tests and the Z code. And then they will say, I believe it says recommended CPT code. That's the code you need to use. Then if they give you 81479, I think this is another thing, Tara, that I just want to clarify for labs, because there's a lot of confusion. If your technical assessment is approved, the MolDx DEX will price unlisted. They will crosswalk and price. So you will get an assigned rate for 81479. So you have to bill 81479. Don't panic. There will be a price assigned. That's what you will be paid. And you should be able to see this in the diagnostic exchange under your test. If it says see fee schedule, it means that there's already a clinical lab fee. So they give you a CPT code like 81455, and then you will be assigned the price. The fee is the corresponding fee schedule on the CLFS.
Thanks, Ann. That's really helpful to clarify. I appreciate your expertise. I'm going to move on to prior authorization now. I love how Ann framed this as kind of the MolDx program being basically prior authorization for Medicare. So I'm going to talk a little bit about prior authorization. We know that's a requirement from a payer that a provider of healthcare services obtain coverage approval before providing a service, including testing when that is required. Payers use this to confirm medical necessity, that clinical utility that we've been talking about. They also use it to confirm the service is covered under the patient's insurance plan, and also sometimes to check that the requested service is cost-effective compared to alternative options. You guys that have requested prior authorization, that you're submitting clinical documentation, including any applicable diagnoses, as well as justification for the services sought in order to obtain the authorization. It offers a lot of administrative burden to providers and labs to obtain prior authorization. And so it remains a barrier to the delivery of timely and cost-effective healthcare for a lot of folks. So I wanted to show some of the impacts of prior authorization. I believe that Alex has linked this survey, somewhere where you can access the full visual yourself and the full results. This is from the 2024 American Medical Association prior authorization survey of physicians. And here I've screenshotted the patient impact. I just want to go over a couple of these statistics because they are important for understanding the negative impact that prior authorization has, so that we can then talk about some of the reforms that are on the horizon. 93% of the physicians polled reported that care delays were associated with prior authorization processes. 82% reported that treatment is at least sometimes abandoned by their patients due to the prior authorization process issues that arise. 1 in 3 physicians say that prior authorization criteria are, in their opinion, rarely or never evidence-based. 94% report negative impacts on patients whose treatment requires prior authorization, and more than 1 in 4 physicians report that prior authorization processes have actually directly led to a serious adverse event for a patient in their care. Now, we can't overlook the impact on physicians and providers as a result. And I know these were physicians that were polled, not laboratorians, but since labs have to jump through some of the same hoops to obtain prior authorization, a little bit of the assumption is made here that some of these results can generalize to the laboratory too. And I thought I'd share that with you and see if you have the same sort of experience in obtaining prior auth for your testing. So for those providing services, they submit an average of 39 prior authorizations per week per provider, which equates to about 13 hours a week in administrative work. Nearly 1 in 3 report frequent denials, with 75% of these providers saying that prior authorization denials have increased in the last 5 years in their experience. 89% of those polled believe that prior authorization contributes to physician burnout. And I just want to point out that given the medical laboratory workforce shortage, we need to avoid burnout at all costs. We're trying our best to retain the important laboratory staff and personnel needed to continue to offer testing that informs 70% of all medical decisions. Only 20% of the providers polled always appeal their denials, their claim denials. And that's because 2/3 of them reported believing that their appeals will be unsuccessful. I told you earlier that about 60% of denials are never recovered. So they're not necessarily wrong. And they just essentially don't rebill, don't appeal, and they miss out on that revenue for perhaps services that are already performed, because that is necessary in some cases, even though you're supposed to obtain authorization first. 61% of those polled reported concern that payer use of artificial intelligence will cause prior authorization denial rates to continue to increase. So this is not a problem that's going to go away, and may even be compounded by the use of artificial intelligence based on their experience that it has already increased in the last 5 years, and now payers are using automation to help move some of this along. And so it remains to be seen what will actually happen, but we do have some reforms on the horizon that I wanted to talk to you about, which is why I wanted to give those statistics as kind of a background baseline of why some of the reforms are happening. Let's talk about Congress first. They've long discussed the pitfalls of prior authorization. But in late May of this year, they actually introduced a bill, the Improving Seniors Timely Access to Care Act. It was actually a reintroduced bill to the House. This is the second time they've considered it. It is bipartisan supported. Last time, unfortunately, it died in committee, but this time it's been referred to two committees, Ways and Means and the Energy and Commerce committees. So I hope that means that they'll move it forward. Obviously, remains to be seen what will happen, especially given the shutdown. But the bill does have 224 co-sponsors, so it is highly supported. If it is passed, Medicare Advantage plans would need to adopt the electronic prior authorization system with standardized transactions. It would provide transparency around prior authorization use, and the requirements would be improved. That transparency of what is required, I will clarify, that will be improved. Health and Human Services authority to set prior authorization determination timelines would be clarified, and agencies, including HHS, would be required to report on their oversight and further improvements to the electronic prior authorization process. So they're trying to mandate that some of these processes be improved. But again, this bill previously died in committee. It's sitting on two committees' desks right now amidst the government shutdown. So hard to say what will happen in the future. What is a little bit more encouraging is that payers themselves, 75% of insurers actually, signed a voluntary pledge this summer. This includes CVS Health, UHC, and Cigna, who vowed in June to overhaul the prior authorization process themselves. Their goals are to reduce the number of services requiring prior authorization by January of 2026. That's literally 2 months away. They're also trying to standardize the electronic prior authorization process to improve transparency and speed, with the goal of full implementation by January 1, 2027, which is about 14 months away. Essentially, the goal is faster decisions. They want to honor existing authorizations, have higher or increased transparency, and get to 80% real-time prior authorization decisions by 2027. This is hoping to lead to reductions in care delays, improve patient experiences, and continuity of care for patients, and more importantly to you guys and your labs, probably reducing the administrative burden for providers. So how do you comply with prior authorization requirements? Despite the reforms, prior authorization is going to continue to be a requirement in many cases. So you've got to be able to navigate it, despite the fact that others are working to try to improve it. The first thing you can do is stay on top of your specific payers' prior authorization requirements. Each payer may have different requirements, and understanding those, remaining up to date on any changes is of the utmost importance. Secondly, advocating is important. You need to advocate with your payers directly to cover the tests that your lab wants to offer. These are tests that are not already covered, but that you're hoping to expand your test menu to include and will allow the growth of your laboratory. Advocating alongside groups in healthcare that are looking to reform prior authorization and healthcare as a whole is also pivotal, which is probably what led to the Improving Seniors Timely Access to Care Act being introduced and then reintroduced, as well as most likely led the payers to make that pledge to improve prior authorization themselves. And then individually advocating as laboratorians, call and email your representatives, support the healthcare reforms that will make a meaningful impact on your laboratory. That's the only way that representatives get any feedback from their constituents, is to hear from you directly. So sending an email and making a call may feel like a drop in the bucket, but if everyone does it, then they will understand what they need to do to properly represent you in Congress. Third, to comply with prior authorization and streamline your processes, adopting electronic prior authorization by knowing which payers accept it and then adopting it to streamline those processes is pivotal in order to meet the prior authorization requirements. It really makes it a lot easier when you can adopt that practice and move forward in doing so with those payers that already accept it. I can't say enough about devoting resources to managing your data and ensuring that prior authorization is obtained, as well as denials appealed in a timely manner. as the complexity of reimbursement and billing just continues to compound, you have to devote it. It is just necessary to devote resources to doing so, whether that is an internal team or working with an outside company that understands the complexities. It is pivotal for ensuring that your reimbursement is regular and you know what you're getting, you know what you're doing. And finally, I wanted to point out that complex care is likely going to continue to require prior authorization even after the reforms. So they're trying to reform some of the basic tests, basic things in terms of patient care. So complex care is going to continue to require prior authorization, which is all the more reason to devote those resources to understanding how to jump through those hoops. So to sum up, my advice, stay vigilant, understand your payer requirements, advocate for fair policies and necessary reform, adopt efficient strategies like electronic prior authorization, and utilize resources to navigate prior authorizations. There's a lot of moving parts for sure. There are paths to navigate it, though. You can navigate and obtain prior authorization effectively and receive your reimbursement. This not only ensures timely treatment for your patients your lab is serving and reduces the administrative burden for your lab, but it also will help to stabilize your lab's revenue cycle management and ensure its ongoing financial health and reliability. I'm going to turn it back over to Ann now to talk about MACs.
Sure. Well, it's not just a MAC problem anymore, Tara. It's really, folks, I'm just going to quick tie back to the prior auth and the reforms, and United Healthcare was on that list. United Healthcare, I will repeat, United Healthcare. This is national for certain lab tests. Commercial, Medicare Advantage, and Medicaid are now requiring labs to register their test into the diagnostic exchange, obtain a Z code, go through the technical assessment, and submit with a CPT and a Z code once that TA is approved. That is United Healthcare's kind of answer to the prior auth reform or prior auth for labs. So you should know your payer mix and make sure that you are looking at those tests. I explained on the diagnostic exchange under FAQs, you should be able to go in and find the list of codes that will require a Z code. Z code and CPT code, two different things, and one does not replace another. You have to have a CPT code on a claim, and then the Z code goes underneath the CPT code in the fields. There's a loop and segment. They've got all the instructions right on the page. But this is national. It doesn't matter what MAC you're in. Same with Humana Medicare. It's national. So if you're in Texas and you have a patient that has United Healthcare, your test may require registration and submission of a Z code along with the CPT code. Again, this is in response to the increased spending that Medicare and payers have had for molecular tests within the last 10 years. Technology, science, way ahead of payers, policy, and reimbursement. This is the evolution of how policy is developed. And once testing becomes standard of care, payers will adopt processes and policy and reimbursement structure in order to allow for this. Not enough CPT codes available. So again, we've got all these lab developed tests, LDTs. They're unspecified. There's no specific CPT code for your specific test. Therefore, the requirement really is that you use unlisted. So if you're using unlisted, there's just really not a way for the payer to identify what test. And so that's why they're putting a lot of emphasis on the front end to ensure that there is a path for the payer to evaluate your test and determine whether or not they will reimburse for it. This is the future. If you are billing for molecular tests, in 2025, you cannot put your head in the sand and think it will not affect you. Payers will require either MolDx and the diagnostic exchange or some sort of prior authorization for certain tests. And so making sure that you understand those rules up front will help avoid costly mistakes on the back end. This is why this is happening. And again, the future, although this seems daunting, this is what happens when more, I would say it's where we're starting to see the development of policy surrounding this standard of care. So in some ways, although again, it's daunting and frustrating, it is also starting to establish some, I would say, some more hopefully streamlined processes so that will reduce that back end burden of having to submit requests for additional documentation, to appeal, to try to get coverage for your tests. All right, so I did want to put in just again, as we finalize our discussion today, just some of the things that are new and emerging within the lab industry this year or the last couple years. So we have a nice slide here. I'm not going to go through all of that, but it's just we put this here, and I wanted to showcase this as far as this business, the future of molecular testing and reimbursement coverage. It's very exciting. It's fast-paced. There is constant new science, and it's very exciting. It's a nice time to live. You know, we are developing technology and science to help cure disease in the future. That's really exciting. So keep doing what you're doing, but understand my guidance of, you know, these models and these features and why, and it's all very good, but it takes time for payers to sync up. That is the structure that we have currently in the United States. And so, you know, it's really important for labs as they develop new testing and they want to, you know, be on the next cutting edge of you know, what's next for patient care. It's important to not just think about that science piece, although it's the most exciting piece, bringing in someone to make sure that there's visibility into the reimbursement, to payer policy, and what that will look like for you and what the steps you need to go through in order to secure reimbursement is crucial for success. I've worked with a lot of labs where, again, they have a phenomenal test and it's very exciting. You just can't get paid for it. And so there are things that, you know, there are steps to take. And the good news is, as I mentioned, we continue to see policy evolve to start supporting this more favorably. But it's very important to align that science with reimbursement. All right, I'm going to wrap it up here with just some, not policy, but really what's going on in regards to Medicare and payment reforms. I don't know if all of you, most of you, I'm sure, are aware of PAMA, which was, gosh, that was, PAMA was established several years ago. It's Protecting Access to Medicare Act. And part of the PAMA Act required, it got away from having the clinical lab fee schedule have the individual localities. We now have a national fee schedule. And part of the way that they established the rates for lab tests on the CLFS is labs have to report payment data from non-Medicare payers. And they take, PAMA establishes, again, the structure where Medicare takes this data and they determine what the reimbursement should be for clinical tests. And so there's a lot of issues with PAMA. And you've seen over the past several years where there's been other bills introduced, like SALSA, introduced to try to debunk PAMA or to establish a new methodology. And so there is now, it's proposed as the Results Act. And the Results Act, it is looking to, again, use more comprehensive independent commercial data from all payer types to establish the Medicare fee schedule. And they're capping reductions. So if you can see the under PAMA, the additional cuts of up to 15%, they want to cap it at 5%. With PAMA for reporting, it was supposed to be every 2 years, and it was going back. That has been frozen for the last 3 years. But the reporting burden is reduced under results, where they're only going to report data for low volume or proprietary tests. So there's not as extensive reporting burden on labs. And looking for that long-term stability where it's not evaluated so often, it's consistent, accurate reimbursement over a period of time. So, we're continuing to monitor Results Act. As I'm aware, PAMA, I believe, is frozen. If we are looking to perhaps have to report data next year for 2019, I believe. And Alex, I don't know if you want to weigh in here, but labs haven't had to report on PAMA data for several years because of COVID, and it's been frozen.
It's essentially been frozen since COVID was introduced, and the public health emergency every year has been a kick the can down the road sort of situation where we work on a fix. And this time it seems like if the Results Act is not passed, that there may be PAMA reporting in the spring, like you're saying, but it's wait and see.
Right.
And if we could kind of move on from PAMA and results, and if anybody has more questions or needs specific info there, we can follow up. But we do have a lot of questions, and I would love to get into some of those before we wrap up here.
Absolutely.
Yep. And just really quick, I want to give an opportunity for anybody who'd like to follow up with Quadax. You can scan the QR code there, see more information about some of the upcoming conferences they'll be attending. And please, if you are looking for a reliable RCM provider, Quadax is certainly your solution. So we encourage you to follow up with them.
I just wanted to say really quickly that I'm speaking at the Q1 conference, that third one that was on that slide. So if anybody is going to be at the Q1 conference in Boston in early December, please come listen to me talk. I'm going to be the chairperson for day 2, so I'll be there all day. I would love to connect with you. So
I'll be there too.
Yay.
Oh my gosh, a chance to meet you both.
It's a party.
Well, really quickly here, because we promised Q&A and we're running short on time here. And particularly one thing I want to dive into, we've gotten this question many times, and I will just say we have more than 50 questions. We're not going to have a chance, obviously, to address the majority of them. Please, if you need more information, use that email address there. Follow up with us, follow up with Quadax, and we'll be happy to get your questions addressed. But, and one thing that we're seeing repeatedly across this is it's not as simple always as just completing your process for a Z code, requesting your technical assessment, and then getting paid. It's not just a hoop process that you jump through, because there are currently roadblocks sometimes to even getting that technical assessment approved. Particularly, we've talked about PCR UTI testing many times in the past, and how we could band together as an industry to find a solution there for an approved technical assessment. Can you just kind of, from a top-down view, speak to that a little bit about how it's not so simple?
No, it's not so simple. I mean, the steps of enrolling your test into DEX and getting a Z code, that's simple. It's the TA part that most often labs will get hung up on. And so what the technical assessment is reviewing is clinical validity and clinical utility. I think with infectious disease right now, the clinical utility, the industry is, at this point, we have not supported enough clinical utility. There's not enough reason where Medicare feels that this is medically necessary. I believe there are many labs that are working on validating this. There are labs that are working on submitting through New York State, which is a separate entity for, that, they have rigid standards as well. But infectious disease, technical assessment, if you are running respiratory, GI, and even STI, there's opportunities there. UTI, wound, and nail fungal, I believe there's still some question. And I always tell the story. I got on with Medicare back when infectious disease was rolled into the MolDx program. And Medicare's words are just still ring very clear to me is we haven't established as an industry that the gold standard, which is culture, isn't as valid as your PCR methodology. So that's what we have to prove as an industry.
So just as a follow-up there, we have another question that's been upvoted many times. Say somebody's performing urine PCR, what are they supposed to do to get paid, or what path forward do they have currently?
So if you're in a non-MolDx Medicare, you continue doing what you're doing. But if you have United Healthcare or Humana, those that test will require a submission, Z code submission to DEX. You'll need to obtain a Z code. And then if they request, so we don't request a technical assessment, MolDx does. Diagnostic Exchange will request that TA. So if the test that you're registering, they want to do a technical assessment, they'll request it, and you have to go through. If your technical assessment fails, you won't be able to get paid for that test from United Healthcare or Humana. Now, right now, United Healthcare Medicare Advantage is the only product line under UHC that requires the Z code for the infectious disease CPT codes. So if you're running UHC commercial or UHC Medicaid, you just go onto that policy under DEX to see if that test requires the Z code, and then look at your denials too.
All right, and then let's try to wrap it up here. And again, we are going to leave a lot of questions on the table, so please follow up with us, info@lighthouselabservices.com. And I'm going to go ahead and throw this QR code back up on the screen. But Ann, get that crystal ball back out that you brought out early. I think you said if you had to guess, NGS would be next on the slate to participate with MolDx. What about the other two remaining MACs beyond that point? Do you think this will eventually cover all MACs?
I do. And if you would have asked me this several years ago, I would have said probably not. But I've seen the director of MolDx speak many times at different conferences, and industry news looking at what what these payers are doing, these MACs are doing as far as LCD coverage and how much they're spending in molecular. Leads me to believe that MolDx is here to stay, and it's going to be, again, it wouldn't surprise me if at some point all 7 MACs roll up under this. And more, I was speaking to someone just yesterday about this, and I believe that Blue Cross of North Carolina might be also looking to roll into this. And so, again, it's really important. I think Tara mentioned it. Staying on top of industry news and paying attention because I feel like this is a program that has shown success, and it makes sense for more payers to want to roll in, because then they don't need to worry about it. It's already an established process.